So I'd like to welcome you all to the second annual National Grand Rounds of Orthopedic Chairs of Canada. We refer to as OCC. Orthopedic Chairs of Canada is what brings the academia in Canada together, the 17 medical schools and chairs of the divisions and departments of orthopedic surgery. We had a good fortune to host last year Dr. Gans, and it was a very well received National Grand Rounds. This year, we're excited that University of Toronto, under Dr. Peter Ferguson's leadership, is hosting our second National Orthopedic Chairs of Canada Grand Rounds. With no further ado, I'd like to introduce the chair of University of Toronto Orthopedic Department, Dr. Peter Ferguson.
Thank you very much, Kishore, and welcome from the University of Toronto to everyone from coast to coast. Before I start, I would just like to give up a land acknowledgement, and I will admit this is University of Toronto and the Toronto region land acknowledgement, but certainly your own regional land acknowledgement would absolutely apply. So I would wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. I would also like to wish a slightly belated Happy International Women's Day and International Women's Physicians Day to all of our female members who may be on this call as well. So this is the second National Grand Rounds, and we had a meeting in January where we talked about what the topic might be and who was going to host it. And so I volunteered from University of Toronto, and there was happiness that somebody was going to take it on. And then Kishore indicated, well, this meeting was in January and said we've got until mid-March to organize this meeting. And I thought, oh, geez, how are we going to do this? So fortunately, at that time, I was on a meeting of our Musculoskeletal Tumor Society, and I was interested in having the topic of AI specifically because I really think that there are many issues that are so relevant to us in medicine and in orthopedics. We had a session on ChatGPT at our faculty development day in the fall, and I was absolutely blown away by the power of this technology. At our meeting of our Musculoskeletal Tumor Society planning, Dr. Weinstein was mentioned as one of the guest speakers on the topic of AI, and so I sent him an email that evening, and he got back to me right away and indicated that he would be happy to present to our group. And we are forever grateful that you are able to join us here this evening. So just briefly, Dr. James Weinstein is currently the Senior Vice President of Microsoft Healthcare. Previously, he was the CEO and President of Dartmouth Health and President of Dartmouth Physician Group and Founding Director of the Dartmouth Institute. He has collaborated with Congress across 3 administrations and proposed the Federal Reserve for Health in JAMA Health Forum 2021. And he's contributed to the AI revolution in medicine, ChatGPT-4 and beyond. And really, in my certainly search around in terms of who would be the most appropriate person to speak on this topic, I could not find anybody more appropriate out there anywhere than Dr. James Weinstein. So he is joining us today from Hawaii, where he spends his winters, and we are extremely grateful you've taken the time to join us this afternoon, and we're very interested to hear what you have to share with us.
Thanks, Peter. It's great to be with you. And as an orthopedic surgeon myself, I'm always happy to talk to my colleagues from around the world. So great to be with you. What I want to suggest is we're in what I would call a necessary ecosystem transformation. This isn't just technology, and I'll show you through my slides, but this is kind of a Copernicus Galileo moment. The world is going to change, and I'm fortunate to be involved in that change at a very grassroots level at Microsoft. I'm not selling anything. I'm not in sales, and I'm in research to look at the next 20 years of healthcare, and I'm going to try to share some of that with you. Then this is just a little background for those of you who don't know me. I'm a spine surgeon by training. I trained at Rush in Chicago, went to the University of Iowa Orthopedic Department. I spent 14 years at the University of Iowa. My main focus was spine tumors, which is very interesting. We had the largest collection of primary tumors in the country, US at the time. And I always thought of those patients, as you might understand, as N equals 1, because they're all different. Then I went on to Dartmouth to lead the Dartmouth Institute, which is a health policy service group, did the Dartmouth Atlas for decades, which studied the US healthcare system, much like the Ontario group does in Canada, looking at variation in practice. And we've published lots of information, and I recently, for Microsoft, worked on Operation Warp Speed. In my office as CEO at Dartmouth, I had one picture, this picture on the right of a glass, and I can ask you why I had that one picture. Obviously, I had family pictures, but this cover of the New Yorker, I would always ask people coming to my office why I had it. I know the Canadian healthcare system pretty well. You have the same issues we do, just use different resources to achieve that. And I know burnout, wait times, access, the usual things are troubling, not just for physicians, but the nurses who we love and care for so much as well. Now, typically technology drives the GDP of a country, a nation, a world. And that's been back since the printing press in the 1500s. And of course, you can see the exponential growth in technology and the exponential growth in GDP as a result of technology. That's pretty exciting for tech companies, but my concern is it could widen the disparities amongst those who aren't as advantaged. And, quite frankly, the United States, with 21% of our GDP, despite great technology, we have the worst health outcomes overall amongst high-income nations, lowest life expectancy at birth, the highest death rates, highest maternal infant mortality, highest rate of people with multiple chronic conditions, obesity, et cetera. So I'm pretty excited about technology. The question is it can actually change anything? And I'm going to challenge you today to think about that change and how we might do it together. And now my colleague, believe it or not, Bill Gates, is said a few things, but we always give credit to Edward Deming that every system designed to get the results it gets. You can look at the Canadian system, the US system. We've designed a system and we're getting results based on that design. And Bill would say the first rule of any technology is that it has to be applied to efficient systems, which then can magnify the efficiency. The second bullet is more important and also true, is that automation applied to an inefficient operation will magnify the inefficiencies. And that's what I kind of worry about for our healthcare system and probably yours as well. And just as an example, I sit on an advisory board at Stanford looking at AI related to healthcare and the administrative burden. And I don't know how well you can see this, but this example of just coding, there's 57 billion regulated prices for 93,000 procedures. So, I mean, it's just kind of chaotic that we actually have this kind of infrastructure that if you're going to apply technology to, as Bill said, that doesn't work, you actually probably not going to change it or make it worse. So there's lots of room for improvement. The paper that Peter mentioned that we published in JAMA about the Federal Health Authority was really my attempt to try to have a solution set, which I'm going to suggest to you that we think of such a set in Canada, and I'll show you some examples. But this pursues a national health policy. You know, the Federal Reserve was set up after our 1907 kind of financial failure. It took 6 years as a country to come back and develop the Federal Reserve to put our financial markets in good stead and to have backup systems for each of the financial challenges we've had, most recently, as you've had COVID. So I won't go into this, but I'm happy to share the paper or whatever, but it really allows for a digital infrastructure to support the things we want to do, care for patients, do research, educate, etc. So and why I started with that is because I said, why not an orthopedic national network in Canada? Maybe you have some, but I've done a lot of NIH trials on spine surgery called SPORT. We worked in 13 states, thousands and thousands of patients involved. I set up a collaborative across the United States with 70 million patients and 70,000 physicians on a digital infrastructure. And I'm currently working with the Bill Gates group on creating a hub and spoke model, which I think is applicable for Canada, for rural parts of the United States, which are really in trouble. And therefore, I'm going to suggest Canada is ripe for this kind of thought process, and orthopedics could be the leaders, as they have been, I think, in the United States in many ways. So this ecosystem transformation is not a technology substitution. We're not just putting AI into something and say it's going to be better, because it's not, as I just articulated for you. But questions do arise. Can AI be improved to improve outcomes and well-being? We'll see. I think it has great potential. Can we ensure that there's no harm and it's safe? Not yet. Can it be trusted to be equitable and fair? And I suggest to who? And I suggest that's in the eyes of those being impacted. Is your data your data? Who owns it? Who owns the associated IP? And can we integrate AI into our work lives and across our communities, which is critical to any potential success? So we know everything's becoming automated. But it's not this technology substitution. You can't just put these fancy machines in place. You have to put them in place in an ecosystem that works. And of course, I could ask you who invented the light bulb, and you might say Thomas Edison, but it says at the top here, hint, it's not Edison. Edison designed the electrical screw situation for the light bulb in 1878, but many, many years, almost 70 years before that, Humphrey Davy invented the light bulb. Edison's genius, which is what I'm talking about today, is really how do you integrate these great ideas like AI into the ecosystem and make it work? And Edison's genius was working with General Electric and other companies to create a power grid in which then light bulbs could actually be very exciting, and to execute on that idea. What we don't want to do, use this analogy, just add another lane to our busy lives. I don't want to get on interstate AI and still take 3 hours to get to work if I live in Los Angeles. In Los Angeles, we often add another lane to the highway. We never fix the primary problem. So you've heard about generative AI, and some of you know a lot more about it than others. I'm just going to take a few seconds explaining how this works. It's the first time we can actually use natural language, our voice, our dialect, the language that we use, whether it's English, Spanish, Hindu, whatever. And then we have a reasoning engine with these large language models that turns this into decision-making capabilities. So it's that platform shift that is changing the world right now. So here's an example, because I think these are intelligent systems, and we can argue about what intelligence is, but this is with GPT 2.5 at the top here. I have a book, 9 eggs, a laptop, a bottle, and a nail. How can I stack them? In GPT 2.5, the early large language models, which were fairly small, gave a pretty bad answer. You can, a way to stack the objects, place the bottle on a flat surface, carefully balance the nail on the top of the bottle, something that wouldn't work. But then you ask GPT-4 the same question, and you get a very logical, very reasoned answer of how to do this. So that's the big transition. These models are becoming so powerful that they are, I think, somewhat intelligent. And another way for me to explain this to you is all of you maybe have read Charlotte's Web, I'm not sure, but you read it to your kids or read it as a child. But these models are not just language. They see, they can read things, they hear things and can interpret them in any language. They can search for things and they can understand them well enough to make decisions. Our brains, as you know, have 86 billion neurons and 1,000 trillion connections, and they work in ways that are quite marvelous. These machines, I think, are intelligent. They don't work quite like the brain, but they have a lot of capabilities. So I showed GPT a picture of the book, Charlotte's Web, and it told me this is Charlotte's Web book. It's a classic children's book that tells the story of friendship between a pig named Wilbur and a spider named Charlotte. And it can do this in Microsoft Word. It can do this for your Excel files. It can make your PowerPoints, which I'll show you, etc. So now here's a question to the group, and I'll ask you, frankly, have you read Charlotte's Web? And I'm not going to count hands because I can't see them. But the point is, if you read it, you have to call on your memory to try and tell you about it. And our memories, mine's not so good, so I need help. But GPT, if I said, who are the main characters, GPT will tell me right away. Now you could find that on the internet and figure out what that is. Then I said, what's the meaning of the story? Again, it's on the internet. It talks about the value of friendship, the power of words and creativity, and the words, the spider's web. It's all fascinating to me. But what does Charlotte's Web teach us about friendship? And GPT has a great answer to that. It talks about the different kinds of friendship at the heart of the story. It suggests the rarest and truest friends are those who are willing to put their hopes and dreams and even their lives online for the ones they love. We all have families and can appreciate that. So then I said to GPT, because I don't have the great memory, I said to GPT, can you replicate the actual copyright book, page 30 of Charlotte's Web? Now, because, you're so smart. But like us, I don't have a photographic memory. GPT can't do that. I'm sorry, but I can't replicate the actual book. That would be a violation of the author's intellectual property rights. I can only provide you with summaries, experts, or an analysis of the book using my own words and knowledge. Now, this GPT says my own words and knowledge. Thank you for understanding. So are you capable of memorizing long text? I asked GPT. I'm sorry, but I'm not capable of memorizing long text. However, I can help you with writing, rewriting, improving, or optimizing your content. So then I said, this isn't on the internet either. I said, how does the Canadian Orthopaedic Society relate to E.B. White's Charlotte's Web and friendship? This is an interesting question, GPT says. I don't think there's any direct relationship, but the COA, as a professional organization, represents the interest of orthopedic surgeons, while Charlotte's Web is a classic children's novel. However, one possible connection could be that both COA and Charlotte's Web share a common theme of caring for others. And it can get quite detailed about this depending on your prompts. But Charlotte's Web is a tender novel of friendship, etc. Both the COA and Charlotte's Web demonstrate the value of compassion, kindness in different ways. Quite interesting. So I said to GPT, what are some of the major challenges facing the Canadian Orthopaedic Society? So it listed a few, not surprising: wait times, access, unemployment, underemployment, lack of standardization, and innovation, which I think here's all what this talk is about. It's innovation. So I'm just going to give you my views and kind of share some things that I think you have an opportunity to think about. Every business, every profession is going to change, from healthcare to finance, education, government, you name it. It's all changing as we're talking. And one of the changes is through a foundation in the US called the Shills Foundation. They're talking about skills first hiring. So no longer are companies just going to hire somebody who graduated with a degree in biochemistry or computer science. They're looking for somebody to do the job using AI to perform screening for healthcare, somebody to understand the medical record system. What skills can we teach that person to then come and be a value added to our system? And this is remarkable. They're going to work with 500,000 HR leaders, hiring managers and C-suite executives, and drive 100,000 employers to implement skills first hiring. This is going to create about 74 million new jobs, they say, per year. It's kind of remarkable, and at higher pay. So when you think about this skill gap, things are moving really fast in the world of AI, and to remain relevant, we must teach ourselves first, and then our students how to learn and learn fast with these tools. Educators need to embrace AI so there's no surprise of its positive or negative impacts. And if you think of physicians won't be replaced by AI, but physicians that don't use AI will be replaced by those who do. Pretty strong statement. I don't know if it's true or false, but my sense is it's pretty true. Now, institutions across the world are now partnering with us to actually implement these strategies across their whole campus. So the University of Michigan was one of our first partners, with 100,000 people turned on with GPT tools like in one day. And if you just look at their use cases, generative AI used for tutoring, gamification, quiz, test design, and more. Medical and academic advising, optimizing how to do their workflows. They used AI to catch bias in resume reviews, and procurement gain insight, spending, and decision-making on supply chain issues. This is just happening as we speak, and the students improved their grades by 7% who used GPT initially, and many times that was one full grade improvement. There's all kinds of companies coming out. I only mentioned one here, Klarna, which is an AI assistant. It's a leading global retail bank for payments and shopping service, and it's partnered now with OpenAI. They've had 2.3 million conversations in the first month and estimated their profit improvement of $40 million. These things are happening as we speak, and just remarkable. So here's my thought. Can we make differences, in this case with the orthopedic group across Canada? I think you need to go what I call on the ecosystem offense. If you've always done what if you always do what you've always done, you always get what you've always gotten. And that's not very good, and we can't afford to do it anymore. And I just give an example. When I ran these large trials in the United States and the High Value Collaborative with 70 million patients, the Wall Street Journal called us the dream team of healthcare. And we really weren't a dream team, but this was started in 2009, so actually quite some time ago. And now with these tools, I think everybody, even at the individual level, can be a dream team person. You realize that 97% of all the data generated by your hospitals remains unused. And when you think about clinical trials and what we call real world evidence, which the SPORT trial was one of the first in spine surgery, we had cost data, we had imaging data, we had patient self-reported data, we had economic data, and we followed those patients over 10 years with NIH funding. The problem was another talk I give called Unsportsmanlike Conduct really was that the profession was worried that I was going to find that surgery didn't work. And so they were writing all kinds of articles, presidential address. We have to be fearful of these kind of trials. And in the end, they didn't know anything about the trial, those who wrote those things. And so I called it the talk of unsportsmanlike conduct. But the media picked it up, and what they picked up really was very positive for our surgical community. This is just a disc surgery cohort, because people said, you know, you can't study all these things at the same time and collect all that data. It's just not possible. We don't have the systems to do it. And I said, but I see all these same patients every day: stenosis, tumors, disc, degenerative spondyle, etc., back pain. I don't want to do just one group. I want to do the whole thing. And so we did do that. And the data was quite remarkable, where we had observational RCT groups, because I was interested in whether an observational trial could be as good as an RCT trial and what the confounders were, etc. And what you found is that regression to the mean in both groups was the most powerful thing. That tincture of time for a lot of the things we see makes things better. Now, it's not going to make a degenerative hip better or a fracture better just waiting, but there are many things we see day to day that tincture of time does make a difference. And when a patient's given what I call informed choice versus informed consent, where they're involved in that decision, looking at data like this of risk benefits, it makes a difference in utilization and outcomes. And we developed tools where individual patients, we reported this for the Harvard Business Review, but they could use a calculator, calculate what their outcomes would be with or without surgery over 8 years before they ever had the surgery. Those kind of tools are going to become much more common. Then you think of the sport data or any data for what your specialty is, whether it's peds or tumors or whatever. You can now use these tools to help you interpret that literature, and I use it every day. So I just took an article, I knew my own paper, and I said, could you tell me about it, just because I wanted to validate it? And then I said, could you make a 2x2 table of the results? And within 3 seconds, it made a 2x2 table for me, easy to understand. I could go to the paper and say, could you explain those odds ratios to me? Could you explain table 3? It does the same thing. I'll show you more examples. So the trend here with AI and GPT is that we're seeing less hallucinations. I'll show you some examples. We're seeing more reliability, less bias, and more transparency of how these are happening. All governments, including Canada, are working on this as well. But you're familiar that, and I don't think this is challenging for these tools anymore, but they can take a medical test, get the right answers over 80% of the time. That continues to, without any special training, without any extra work. This is GPT. There are other models that aren't as good. They have to keep redoing them, keep retraining them. But this is just a question of a young child with glomerulonephritis post-strep, and what test would you order? And of course, it's easy for it to get the right answer. But the interesting thing to me isn't that it just gets the right answer. It tells me why the other answers aren't good. This because, this reasoning, this judgment. And, whoops, sorry, I went too fast. But we've published a lot of this in the major journals. And you can see here at the bottom, just in the answers to the question, the other options are less likely, in this case, because. And it explains why those answers are largely not the answer of choice. And this is what I said, no prompting, no special training. And this is with GPT-4. It also, I think, has the ability to express emotion. So I said to GPT, what do you think this girl with glomerulonephritis post-strep might be thinking or feeling? Now, it says, as an AI language, I can't directly assess a person's thoughts and feelings, but I can make an educated guess based on what you've provided. And it's quite remarkable what it comes up with, that, you know, her concerns, missing school, having her period, being embarrassed, the swelling of her legs, all the things we see in practice. But the fact that she understands, it understands, and we can have this conversation or help write your post-visit letters is just remarkable. And they, quite frankly, they write it much better than I do and much faster. So here is you have to, the prompting becomes really important, and having promptathons is a thing to think about. But if you were Meg's doctor, I would take a compassionate and empathetic approach to address her concerns and provide comfort and support. So I asked it to write a letter providing comfort and support. And it does that beautifully. And I won't read it to you, but it's remarkably insightful and compassionate. And studies have been done. Several randomized trials have now been done. This one's from UCSF in California, comparing the physician versus GPT responses to patient questions. And the doctors rated these. The doctors themselves rated these. And in every case, they rated GPT as more compassionate and more specific in the responses. Kind of scary, but true. So now I say for myself, for my practice, can you write an email to Meg's mother explaining the next steps? And I'm very specific about the tone should be direct but optimistic, because she has a serious problem. So, dear Mrs. So-and-so, Mila, I hope this finds you well. I believe Meg is very ill. We need to work together to help her get well. I'm optimistic that the right support and treatment plan can make a full recovery and active optimal and being active optimal health, et cetera, et cetera. Just remarkable. So for imaging, you know, important to orthopedics and lots of specialties, it's really going to change the game in many ways. And I'm not going to read these, you can read them. But the fact is that when you know what part of the X-ray or CT or MR you really need to concentrate on, AI can help you do that and be much quicker in getting the images, much cheaper for the patient, less time on the table, and better for diagnostic skill. So there's lots of things happening in this space that are quite interesting. When you're thinking about screening patients for breast cancer, in this case, you know, who should have a mammogram in Toronto? I mean, that's probably an important question, and AI can help to get you to the, you know, the 1,000 people that need it versus screening everybody right away. Where in the United States, it's a quality metric, so we have to screen all people over a certain age, et cetera, et cetera. And not only does it tell you who to screen, which is important, and it does that appropriately, that, as you know well, decreases the mortality rate because you get to the right people faster. really impressive. I did a talk for the American Dental Association, used teeth, and same thing. They were just blown away with these GPT's ability to read oral x-rays. And in education, all of you, I hope, are familiar with Khan Academy. Now there's Khan Migo. Initially, the state of New York banned it. Now it's changed that and uses it in most schools. And Sal Khan, who started Khan Academy with Bill Gates' support, has Khan Migo, where every student in any language can have a tutor 24/7. Just remarkable. And so if you're wanting to do medical education, residency training, etc., you can use GPT as a simulator, and it can act a different role. So I'm in training to be a doctor. Please act the role of Meg, our patient. I will be her doctor. Let's have a conversation as though she's come to me in my office. I'll start. Hi, Meg, your mother tells me blah, blah, blah. Your legs are swelling. Can you tell me how you're feeling? Yes, doctor. My legs are swelling. You saw this from the, I'm worried because I saw blood in my urine yesterday. I had a sore throat with my strep infection, etc. Okay, I see. Well, let's see if we can get to the bottom of this. Let me first look over your vital signs that the nurse took. That looks fine. They look good. So then let's take a look at your knees. Can you sit up here? Now, GPT is saying, can you sit up here? It doesn't see anything. It just knows that's kind of the approach. And then the doctor, sure, doctor, Meg says, GPT, let me sit up on the examination table. I mean, it's just remarkable how it puts these things together using these models based on Bayesian theory and probabilities. And so real cases are happening. Here in the emergency room in Beth Israel Deaconess in Boston, they're using it to help train their residents. And here a young patient went, I think, 14 doctors, 17 doctors over 3 years with chronic pain, 4 years old, having trouble walking. His mother got frustrated and said, I'm going to try GPT. And so GPT said, you have a tethered cord. Now, it was right. The little boy is fine. But think about this for rural areas, isolated communities. And what are we going to do? And your system's different than ours around payment, but these are tools that make things available to anyone, anywhere, which is just remarkable. So I just show you some examples for nursing in case there's some nurses in the audience, but nurses are always doing IV infusions. They need to calculate what the drops per minute are. There's formulas for that. That's pretty standard. But then you can say, well, thanks but in the future, I'd really like to have an app to do this for me. So here's an example of a JavaScript app GPT wrote within seconds that then you can plug into your computer as a link, and any nurse can use this to calculate drops per minute anywhere, anytime for any patient. I mean, it's remarkable. At Microsoft, I think 50+% of our coding is done by GPT now. Copilot, if you haven't heard about Copilot, which you probably have, most everything at Microsoft now is Copilot. That just means with every Microsoft tool, you have a personal assistant who can help you with everything. Half web searches go unanswered. That'll never happen with Bing. Bing search using Copilot. GPT allows for a conversation. You can dialogue back and forth, and it increases efficiencies and productivity. So everything that you have in your data systems across your hospital, whether it's your electronic health record, if you're using Teams like we are today, it can summarize these meetings. It can put together a SWOT analysis of a meeting for you about a business strategy. It can do your Excel spreadsheets and tell you how the business is doing each quarter. You decide, and it can make the slide presentation to present to the leadership within seconds. It's just remarkable. And some of you I know in Canada are familiar with DAX, and I hope some of you are using it from what I'm told. But my goal here when I came to Microsoft was I wanted doctors' hands off keyboards. I was part of the team that recommended acquiring Nuance, which we did, very expensive, but I think voice and this kind of work is the future for healthcare, orthopedics, especially. I found it extremely interesting and helpful. And you can do it from anywhere on your phone. You don't have to be in the office. It's ambient listening you're familiar with. You can do telehealth visits that way. It collects the exact patient encounter. It understands who's talking, whether you're talking or the patient's talking. It captures every word quite accurately. And then you can ask it to take that. Can you write a SOAP note for me and put the appropriate billing codes, which are important for the United States? And it does that fast. Now the doctor has to sign off on it and agree to it and everything, but it's pretty remarkable. And of course, I'm going to take a drink, but we've partnered with Epic now. And Epic says, with the patient at heart. I think with our partnership with them, I changed that now to the doctor at heart because it's actually making our lives easier. It can go through my email, it can go through my patient notes, it can help rewrite things. And of course, as you might know, they created Cosmos with Slicer Dicer, which is their data system of all the patients. It's de-identified data, synthetic in many ways. You can do customized searches, and therefore it doesn't require the approval from IRB because these are all de-identified synthetic patients. And you can ask it questions about, can you show me 500 patients with diabetes type 2 on Ozempic and how they compare in different regions of the country, whatever. And this is an ongoing relationship. You can use your own data as well, but this is an Ozempic question. I was curious how many people are diabetic who are on Ozempic versus not, and it's about 50-50. Some people just want to be on it for weight control versus actually being diabetic. So it's quite interesting. And, the story is out on all these things, but it is remarkable. They are changing things dramatically. If you haven't heard of RAG, RAG is an information retrieval system. All these tools are available to you in the Microsoft suite. So everything I'm showing you, you can do yourself. I mean, literally yourself. And they can connect your data with these tools, organize it into a structured way to actually query it to get answers about your patient volume. So it's quite remarkable. Every organization that has aggregated data has to have a RAG. That's my opinion. You have your personal data scientist. And of course, as we move into this AI world and everything's kind of remote, whether it's patients with their Apple Watches, socioeconomic issues, which I'll show with you, we're going to have much more information to actually aggregate to tell us a lot more about our patients. As I showed you, 97% of your data in your systems currently isn't used. We want to use all of that data. And here in Los Angeles, we used it to predict homelessness. So before somebody becomes homeless, can you get upstream? And in that vein, we worked on a hackathon project, which we're putting together what we call social services co-pilot using the 211 database. We have 50,000 calls a day for people needing support for food, housing, paying bills, etc. And using social services co-pilot, we can direct them to those things right on their cell phone, and they don't have to wait. For those doing research, this will be your best research assistant. Here, just take a New England Journal of Medical article or take any article you want and ask GPT to summarize it. Here I did ask it to summarize it in bulleted format. And of course, it did that quite well. I didn't know anything really about this article, and I learned quite a bit in seconds. And diabetes obviously is a really important problem around the world. So it was, I thought, interesting to understand. And then I can say to GPT, I don't understand. Can you summarize this at an 8th grade level so I can better understand it? And it can do that within seconds. So hallucinations, I mentioned, I took sport as an example because I, did the study, I knew the results. Is sport the first study to simultaneously compare non-operative and operative care in an RCT and observational cohort? And they said, no, sport was not the first. They mentioned Weber's study in 1983, which some of you might be familiar with. Weber's study was not an observational and RCT cohorts. So I wrote back to GPT and I said, Weber did not have a simultaneous observational and RCT design. He simply randomized patients to operative and non-operative treatment. And GPT is, oh, thank you for correcting me. You are right. The Weber study did not have simultaneous. So hallucinations happen. GPT is very kind in apologizing, but we can't afford mistakes. So we need to keep working on this. But everything's happening so fast. This is just an example of Soro, who worked with OpenAI to have text to video. So you can say, I want a video of a turtle swimming. See if I can get this to work. And all of this is artificial synthetic. None of this is real. But you could have a picture of yourself swimming, in Lake Ontario, whatever you wanted. It's just remarkable and very quick, just by you asking it to do that. So let me just get into a little of the biology science, and then I'll finish up here. As you know, biology is staggeringly complex. I do think N of 1 treatments are possible. We have trillions of cells, 20,000 genes, 300,000 mRNA molecules. It's pretty daunting. And why developing new drugs cost about $2 to $3 billion per drug. And the clinical trial success rates are only in the 10 to 15% rate. And most of them aren't generalizable because they don't include the populations for which the drugs are given. And there's no guarantee of treating disease and improving patient outcomes. I have lots of data showing that many of the common drugs only work in about 30% of the people they're prescribed for, even with the correct diagnosis. It's pretty remarkable. So I think we're in a new age. I'm calling the golden age of bioengineering for biology, where we can predict and manipulate complex biologic systems. And that's because of deep learning advances, cost reductions for collecting data now, as I just talked about, and the precision editing of DNA with things like CRISPR that you're familiar with. And one of the first examples was sickle cell, costing $1 million per person. But now here's an example of proteins folding. And whoops, go back here. See if I can get this to go. I don't know if it's going to work, but on the left-hand side, it folds part of the way. On the right-hand side, it folds all the way. And I'm not sure why it's not going, but that animation stops, doesn't get very far. And the reason it would take several thousand years using the current compute capacity, several thousand years using current compute capacity to do that. And on the right-hand side, it totally unfolds. And this was accomplished with Graphomir, which is an open source GitHub program. And that kind of work, which, helped for COVID, obviously, was critical. And so this next 2 slides really says that, mathematics is the language of the universe. And the written language, A, B, C, D, etc., is the language which humans understand the universe. But today, as we think of electrons being able to be described and manipulated, molecules, all the way up to humans, we're going to be able to have tremendous increase in drug discovery. And I think this epigenetics, as we all know, is a great part of healthcare. But now you can get an organ, a biopsy, you can look at the cells, you can look at the molecules, you can look at the DNA, RNA, etc., all the way down to the electrons. We're going to see a total different world. And Copilot, for the human things I've been showing you, can also now be applied to science, which is quite remarkable. So we'll have the ability to understand language of humans and the language of nature. And each of you can have your own Copilot every day as a companion. So generative AI is a journey for individuals and for organizations like COA. It demands patience from leaders. But in all disruptions, while taking a wait-and-see approach might be wise, those who move forward will become the future leaders. And as you might know, some of you know, my wife and I lost our first child to leukemia at age 12. Today, she could be cured. And so this affects real people, real time, including myself. So I want to thank you for the time to be here. The glass that I showed you in the beginning on the left of that picture in the upper right was the New Yorker cover. And the reason I had that picture in my office is because I knew what the problems were in healthcare. I knew what the problems in my system, departments, etc. were. I needed to figure out the answer and needed the right glass. And frequently we put the wrong glass to the wrong problem. Thank you very much.
Wow, that was phenomenal, Jim. Unbelievable tour through, really something that we're, I think, just about to start scratching the surface of. And, I think that, my eyes are open to some of the possibilities that we can utilize this for, like right off the bat. And so really appreciate you sharing all those with us. So we have got some questions. I see Rick Buckley has a question. Hopefully, Rick, you can ask the question.
Yeah. Just turn your microphone on, Rick.
If not, then chat, type it in the Q&A then, Rick, but you should be able to.
If you take your microphone off mute, yeah. Oh.
Not going up. Can you type it, Rick? So just, you alluded to our association, Jim, while hopefully Rick's typing his message. So what role do you think, ourselves, subspecialty societies and so on can play while this, incredible transformation is taking place?
Yeah, thanks, Peter. I think it's an important question. The question, the issue is you can't be a bystander. So it's going to happen all around you. The question is who's going to lead it, in this case, in the orthopedics world, medical world. I've, as I showed you, created a lot of collaborations over my career across the country to do things I couldn't do myself. And working in those collaborative efforts is not as complicated as people think. And with the digital infrastructure I just showed you, it becomes quite easy. And so I think it's a commitment to have, let's say, a national orthopedic data system. And it can all be, de-identified, synthetic. Nobody has to, you don't want to harm people, you want to help people. And we don't want to judge people, we want to all get better. And so I think I've done this several times in my career and now with a large company, and we're starting to see these kind of collaboratives happen where they're looking at artificial intelligence, how it's actually being monitored with oversight, and groups are being formed to do that, and many have already signed up, but it's the usual players, Hopkins and MGB, Providence, etc. Many are signed up already to work with us to start that data aggregation. But I would start with, however the society wants to do it. I'm talking to all the medical school deans next week of the United States and Canada, the AAMC. I was their guest speaker at their last meeting. They asked me back to start on this very question, to start to, what are we going to do? And the problem is it's already started. The cat's out of the bag. And I think your leadership, Peter, and the people on the call here really need to come together with, a couple things, not 1,000 things. Right. And I know the Musculoskeletal Tumor Society is interested in the same thing, but forming these data systems is pretty easy today. The tools are remarkable.
Thank you. Okay, so the question, Rick's question, related to bias, saying bias is the big issue, and how does this get handled rationally?
Yeah, well, bias is unfortunately, we're all biased. So whether we acknowledge it or not, the idea is to collect everything. And so if you take most clinical trials, especially with randomization, the number of people who are willing to randomize is a selection bias in itself. Then if you want to get cross-culture, cross-race, cross-geography, etc., it becomes more biased. And so when I look at the literature, and this is a problem in all of the literature, every article you pull up has some problem because they only enrolled 50% of the people, only 50% were followed longitudinally, blah, 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 blah. The only way to change that, I think, is with this real world evidence where we collect data on as many people possibly, even passively. So the Cosmos data system from Epic is interesting, but those are only people who interfaced with the health system. What about everybody else? So you want to use, and I think Ontario has done a lot of work with population health and done some great work in collaboration when I was at Dartmouth on population variation, where people live, geography is destiny, lots of interesting things. So the bias is inherent in how we do our work. To take the bias away, we have to have generalizable populations and representative samples. Absent that, we're not going to do it. Now, what's nice about these models, there's even small language models that can use much less data and get similar and even better responses. So if you have skin lesions in African Americans versus white, if you're only using white patients to determine what those skin lesions might be, you're going to have biased results. If you get a sample which isn't necessarily an equal sample, but a representative sample, you can start to negate the bias. So a lot of these things is a very important question, but we've created the bias by the way we've done our work and the patients we've enrolled. Nobody's fault. That's just how it works. People drop out. They don't want to participate. We have to kind of work around that somehow.
Okay, so we just one last question, because we're just at 9:00 p.m. here, Eastern time. Ahmed Achray just asking if you can just explain briefly the difference between AI and machine learning.
Yeah, I mean, AI is not new. AI has been around. It actually was first coined at Dartmouth in the 50s. I think the notion that I think 99% of it is machine learning. So everything is the machine's learning things, and then AI is how it's interpreted and put together. But if you take images, X-ray images, most of that is that machine learning of those images. So AI is just a part of larger machine learning.
Okay, and then that was nice, succinct answer. So I'll just go to the last question. Dave Nagpal, talking about the relationship between AI industry and healthcare. And to cut to the chase, how do we decide which companies get access to which data and with whose permission?
Yeah, so it's really important. So I only can speak for Microsoft. We don't want your data. You should use your data and our tools to interrogate it. We don't, anything you do on our sites, we do not use. So if you're using GPT for any reason, we do not collect your data. We throw it away. We do not use any of your data for our models. So I can only speak for Microsoft, but that's our policy.
Okay, so we're just a couple minutes after 9 p.m. Eastern, so I think we'll call it for the evening. Jim, on behalf of the COA and the Orthopedic Chairs of Canada and University of Toronto, I'd like to thank you very much for joining us this evening. I think this has been a tremendous talk. I know I've learned a ton, and certainly I'm gonna look at many of these platforms and how this can apply to sort of practice going forward.
Peter, just for everybody on the call, just take your cell phone and download the new Bing. It's free. It's free, and make sure you answer the questions the way you want to answer them. But then use Copilot GPT-4 free every day and learn how to use these things. It's simple, and if it's one takeaway, take that and do it yourselves. And I'd love to get your feedback.
Fantastic. Thank you very much, Jim, and thanks everybody coast to coast for attending this evening.
Take care.
Thank you.